In this session, we'll be dealing with the prenatal diagnosis and genetic counseling. So prenatal testing. So there are two terms here, prenatal screening and prenatal diagnosis. Prenatal screening is screening for all antenatal mothers to identify pregnancies at risk for common genetic disorders. And prenatal diagnosis is confirmatory testing for specific genetic disorders for which increased risk is identified. So this is generalized screening, but here we are going towards a particular disease which has to be diagnosed. That's why this is diagnosis and this is screening. So indications for prenatal diagnosis or screening: maternal age more than 35 years, family history of any congenital anomalies, and the history of mother who is a carrier of X-linked disease such as hemophilia, history of previous child with birth defects, and known genetic disorders of parents like thalassemia. So infections during pregnancy, any exposure to contraindicated drugs, ultrasound showing fetal abnormalities, population at increased risk of genetic diseases, and over anxious mother. So these are the indications for prenatal screening. Now we can see that methods of prenatal diagnosis. So if we go with the non-invasive methods like a prenatal checkup of mother, especially the external examination, then ultrasonography, fetal Doppler for heart, and this is like pre-implantation genetic diagnosis, which is especially seen in IVF, in vitro fertilization. So before the zygote being implanted, this can be done, pre-implantation genetic diagnosis. Then maternal serum screening, so triple screen. So we'll see what is triple screen and quadruple screen in further slides. So you can see here minimally invasive methods include maternal screening for circulating fetal cells, fetal cell in maternal blood, then circulating cell-free fetal DNA, CFF DNA, then beta human chorionic gonadotropin, alpha fetoprotein, pregnancy associated plasma protein A, estriol, inhibin A. All these markers can be identified in the maternal blood. Then transcervical retrieval of the trophoblastic cells. Next, you can see here invasive methods, so which are an extensive invasive procedures, namely amniocentesis, chorionic villus sampling, fetoscopy on fetal liver, skin and muscle biopsies, then fetal blood sampling called PUBS, percutaneous umbilical cord blood sampling, otherwise called cordocentesis. All these are invasive methods. So let us start with the commonly used prenatal diagnostic tool, ultrasonography, used from 4th week to completion of pregnancy. Uses confirmation of pregnancy, either it is single pregnancy or twin pregnancy, fetal and placental positions. Placental position like placenta previa, all these can be detected early. Determination of gestational age and fetal growth monitoring, whether the growth of the fetus is appropriate for the gestational age or not. And if it is not appropriate, we can further screen or further do certain investigations which will help us to identify the factors inhibiting the growth of the fetus. Then detect developmental defects like polyhydramnios, oligohydramnios, and encephaly, hydrocephalus, spina bifida, polycystic kidney, limb deformities, cardiac anomalies, GIT anomalies, like this. All these anomalies can be identified on ultrasonography. So we call it as anomaly scan, which is especially done at the age of 20 weeks of gestational age. Next, you can see nuchal translucency. You can see here. So accumulation of fluid under the skin at the back of the baby's neck. So it is measured using ultrasound between 11 to 13 weeks. Increased nuchal translucency is indicative of Down syndrome. So further ultrasonographic enhanced like 3D scan or 4D scan, you can see here. Still picture of the fetus for detection of fetal anomalies can be obtained using a 3D scan, and we can use 4D scan where 3D image of moving fetus can be generated. So amniocentesis, it is an invasive procedure. It is used to collect amniotic fluid for analysis. So 14 to 20 weeks gestational age is ideal. Ultrasound guided amniocentesis is performed. I will show you in the next diagram. 10 to 20 ml of fluid collected, centrifuged, and isolated amniotic cells are subjected to grow in the culture media, and karyotyping for chromosomal abnormalities is done. And supernatant amniotic fluid, we can find out alpha fetoprotein and other biochemical parameters. So risk for abortion is 0.5 to 1%. You can see here the needle is inserted into amniotic cavity and amniotic fluid is being taken for screening, and here you can see the ultrasound guidance under which the amniocentesis is performed. You can see the layers like skin, abdominal wall, uterine wall all being pierced, entering into the amniotic sac. So screening benefits: chromosomal disorders like Down syndrome, Turner syndrome, and genetic disorders like cystic fibrosis, sickle cell anemia, and neural tube defects like spina bifida and anencephaly. All these can be identified by increased alpha-fetoprotein. Then quantitative fluorescent PCR for rapid detection of aneuploidies. Limitations: cannot detect structural birth defects like cleft lip, cleft palate, cardiac malformations. Any structural defects cannot be identified. Then you can go for chorionic villus sampling. It is also same like that, performed under ultrasound gradient, but here it is not amniotic fluid, it is the chorionic villi, which are aspirated from placenta for testing. So it is slightly earlier than amniocentesis. If you see, it is 10 to 12 weeks, and if you observe here, it is 14 to 20 weeks. So USG guided two approaches: transcervical approach, cervix of uterus, and through the cervix of uterus the sample is collected from the placenta, and transabdominal approach, so needle inserted through the anterabdominal wall into the placenta for sample collection. You can observe here, so transcervical approach to reach the placenta and collect. Again, this is also ultrasound guided. Here transabdominal approach directly into the placenta. So two approaches, the placenta is collected. So if you do placental biopsy, if you use the term placental biopsy, it is used for chorionic villus sampling, which is performed in the later stages of pregnancy. So if it is in early weeks, we call it as chorionic villus sampling. So risk of abortion is 1 to 2%. The merits: early diagnosis because it can be performed earlier than amniocentesis, better genetic analysis and rapid diagnosis than amniocentesis. If abnormality detected early, so maternal termination of pregnancy can be performed safely in the first trimester. So demerits: higher risk of abortion compared to amniocentesis. So it was 0.5 to 1% with respect to amniocentesis. Here it is 1 to 2%. The neural defects cannot be screened because not availability of alpha-fetoprotein. Then cells from CVS can show mosaicism, which might not be seen in fetus. So there might be maternal cell contamination, and structural abnormalities cannot be detected. So maternal blood serum, so these are the following, already I have explained them, like circulating fetal cells in maternal blood, circulating cell-free DNA, circulating cell-free fetal DNA, please remember fetal DNA, then beta HCG, human chorionic gonadotropin, alpha fetoprotein, pregnancy associated plasma protein A, histiol, and inhibin A. All these markers can be identified from maternal serum. So like we can see here, triple screening test, also called AFE plus or Catering's test or Boat's test. So three markers like maternal serum, alpha fetoprotein, so this actually secreted from the fetus, and HCG, human chorionic gonadotropin, which is secreted from placenta, and unconjugated histiol, which is secreted from fetus and placenta. So this can be done from 15 to 18 weeks gestational age. Sensitivity is 70% for detection of Down syndrome. Quad screening test, you can see the maternal serum, HCG, and conjugated histiol. In addition to that, there is inhibin A, which is secreted by placenta and ovary. Four markers can be identified. That's why it is quad screening test. So then comes the chordosynthesis or PUBS, percutaneous umbilical blood sampling. So you can see percutaneous umbilical cord blood sampling. So fetal blood sampling or umbilical vein sampling. So umbilical vein is the preferred one. So USG guided, under ultrasound guidance, a needle is inserted into umbilical cord through anterabdominal wall to collect fetal blood. So rapid detection of chromosomal, genetic, and hematological abnormalities. So rule out of mosaicism is detected. So this is very important. So this mosaicism can be confused between mother and fetus. So this is especially seen in amniocentesis and CVS, which is not seen with respect to percutaneous umbilical cord blood sampling, because it is directly the fetal blood which we are studying. Then risk of abortion 1 to 2%, infection and blood loss from the site of puncture. So here if you observe, see the needle directly inserted into the umbilical cord, blood collected from the umbilical vein, and it is performed under ultrasound guidance. So fetoscopy, endoscopic visualization of the fetus, amniotic cavity, placenta, and umbilical cord. Again, this is also under ultrasound guidance. A scope is inserted through the abdominal wall. So indications to take skin biopsy, surgical interventions like catheter insertion in urinary tract. Risk of abortion is more 3 to 5% due to advancement of ultrasound itself can detect so many anomalies. Fetoscopy is reduced. And then lecithin sphingomyelin ratio, especially for lung maturity. If it is more than 2, mature fetal lung, 1.5 to 2, mild to moderate risk, and less than 1.5 it is high risk. The amniotic fluid index, amount of amniotic fluid is observed using ultrasound and expressed in centimeters in 4 quadrants. So overall it is 8 to 11 centimeters, which is normal. If it is less than 5 centimeters, we call it as oligohydramnios, and if it is more than 20 centimeters, we call it as polyhydramnios. So pre-implantation diagnosis, which is especially when we are dealing with in vitro fertilization. So screening test for the cells from pre-implantation embryo detects metabolic, genetic, and chromosomal abnormalities. Indications are advanced maternal age, recurrent pregnancy loss, repeat IVF cycle failure, and unexplained infertility, abnormal previous child, and history of X-linked or autosomal or metabolic disorders. So all these are the indications for doing pre-implantation diagnosis before implanting the IVF zygote or embryo. So procedure, so after fertilization, polar bodies or plastomere cells are collected and subjected for testing. Disadvantages, invasive procedure, risk of ovarian hyperstimulation syndrome, multiple birth defects related to IVF procedure, then does not screen for all genetic diseases, does not detect phenotypic disorders. So alpha fetoprotein, this is synthesized by immature fetal liver cells. So in healthy non-pregnant females, there will be low levels. In pregnancy, AFP levels increases in maternal serum, urine, and amniotic fluid. So raised AFP levels in neural tube defects, especially spina bifida and encephaly. So incorrect gestational age and multiple pregnancies. Also there will be raised AFP levels. Then you can also see sacrococcygeal teratoma. You can also see renal anomalies, cystic hygroma, liver necrosis. All these conditions AFP levels are raised. So NIPT, non-invasive prenatal testing, like the earlier what we told, no, cell-free fetal DNA. So this, few say minimally invasive, few say non-invasive. If I say invasive, it is for mother. If I say non-invasive, it is for fetus. So cell-free fetal DNA derived from placental trophoblastic tissue. 6 to 7 weeks of gestations is the ideal age where this cell-free fetal DNA starts circulating in the maternal blood. But if you want to conduct an NIPT successfully, so we have to wait up to 11th week of gestation, because then sufficient quantity can be taken. So advantages, no need for fetal invasive procedures, detects Edwards syndrome, Patau's and Down syndrome because fetal DNA is available. Disadvantages, maternal blood has only 80 to 90% of maternal cell-free DNA and 10 to 20% of cell-free fetal DNA. So this 10 to 20%, if it is not sufficiently collected during sampling, then we'll be failing. We'll be performing the test on the maternal DNA rather than fetal DNA. So indications, maternal age more than 35 years and anxiety of invasive procedures. If the mother does not want any kind of invasive procedures for the fetus, she can opt for this cell-free fetal DNA. Then procedure for ml maternal blood collected, cell-free fetal DNA isolated depending on suspected anomaly, genetic tests are performed. Uses detects X-linked recessive disorders, single nucleotide polymorphisms. Limitations, fetal or maternal mosaic, multiple pregnancy. Cannot detect phenotypic findings, very less quantity of cell-free fetal DNA is available, cannot detect fetal anomalies. So PCPNDT Act, this is what which governs all this prenatal diagnostic test. So prohibits sex detection and sex selection to prevent female feticide, regulates prenatal diagnostic procedures performed in genetic centers, registration, record keeping, qualified personnel, penalties for violation. So it's amended in 2003 for inclusion of ultrasound clinics under this law. Then imprisonment up to 3 years and 10,000 rupees fine for initial violation. If it is on repeat, then 5 years imprisonment, 50,000 rupees fine, and name of the practitioner removed from the council for 5 years or permanently. So in 2018 amended, 6 months USG special training required for quality control and prenatal diagnosis only. So then coming to the genetic counseling, so it is nothing but once we do the prenatal diagnosis, this has to be conveyed to the parents and relatives. So the art which is required is through genetic counseling. So it is the clinical counseling of a patient or his or her relative who is at risk for a genetic disorder. Aim is provide information on genetic disorders, diagnose the case and other family members who are at risk, assess the inheritance pattern, provide medical and psychological support, advise prevention of hereditary diseases. So these are the aims. So indications, So many indications are there, like family history of genetic diseases, maternal age more than 35 years, fetal anomalies, consanguineous marriage, repeated miscarriages, infertility, teratogen exposure in pregnancy, child adoption, developmental delay, disputed paternity, diagnosed case of genetic abnormality, and suspected case of inborn errors of metabolism. All these are the indications for undergoing genetic counseling. So steps in the phase 1, it is the assessment, clinical history and pedigree charting. In phase 2 is the diagnosis. So phenotypic screening, molecular screening, chromosomal analysis and prenatal diagnosis. So stage 3 is analysis of both phase 1 and phase 2, assessment and diagnosis. So we have to do the risk estimation, mode of inheritance and the pedigree charting, and results of various diagnostic tests. All should be analyzed properly. Then phase 4, the most important phase, is the communication. So here comes the role of the genetic counselor. So to explain information gained from the analysis, and the information should be ethically transformed regarding the information about the disease, emotional support, education on the disease involving and its risk, and advice on treatment, prevention and rehabilitation. All options should be properly communicated. All options should be properly communicated. So phase 5, treatment and support. So advice on gene therapy, stem cell therapy available for the disease, supportive measures if treatment is not available. Then phase 6, prevention and follow-up. Ask for multiple visits for psychological counseling, advice on the risk of transmission of disease to next generation, and planning of next pregnancy. You can give them options of IVS and assisted reproductive technology or surrogacy. So many options are there. So all this should be given properly. So here comes the main role of the genetic counselor. How he communicates, how he prevents further genetic diseases within the family, and how he helps the couple to have a healthy baby. So we have completed the prenatal diagnosis and genetic counseling. Thank you.